Good afternoon, everyone, and welcome to today's webinar on the Personal Health Information Act. My name is Annette Johns, and I'm the Associate Director of Policy and Practice with the Newfoundland and Labrador Association of Social Workers. I will be your moderator for the session this afternoon. This is a topic that is of great interest to social workers, and we have members from across Newfoundland and Labrador tuning in today. As noted in the 2018 NLASW Standards of Practice, social workers must be familiar with the laws and regulations relevant to their practice and comply with provincial and federal legislation that is applicable to their practice. The Personal Health Information Act is an important piece of provincial legislation that social workers need to be aware of in their practice and is a great topic for today's webinar. This webinar is a collaboration between the Newfoundland and Labrador Association of Social Workers and the Canadian Association of Social Workers. The webinar presentation will be approximately 60 minutes, followed by a 30-minute question and answer period that I'll moderate. Please send in your questions throughout the presentation, as only myself and the presenter will see them, and we'll all keep a track of the questions as they're coming in. All of the housekeeping details you need, like how to access the recording, where to download the slides, and how to get your certificate of attendance, are all included in the housekeeping widget that popped up when you first logged on. Members may claim 1.5 CPE hours for this session under the required category of workshops. I now want to introduce our speaker, Stacey Pratt. Stacey is an Access and Privacy Analyst with the Office of the Information and Privacy Commissioner, OIPC. She has been involved in this position for over 10 years. During her career at OIPC, she has managed complaint and offense investigations, conducted research, and has been involved with advocacy matters. She is currently primarily focused on providing education and training in relation to ATIPA 2015 and FIA. So without further ado, I will now pass things over to Stacey to begin her presentation.
Thank you, Annette, and welcome everyone. I hope you can all see the presentation and hear me well. So we'll get started. The Personal Health Information Act, FIA for short, came into force in 2011. It contains the rules surrounding the handling of personal health information, commonly referred to as PHI. The Act is similar to the older concept of patient confidentiality. However, the rules under FIA are more specific. Additionally, FIA applies to custodians involved in the delivery of healthcare services in both the public and the private sectors of Newfoundland. This is distinct from the ATIPA 2015, which deals with personal information and is only applicable to public bodies within the province. The purposes and objectives of FIA are simply referred to as a balancing act. What FIA does is create a consistent set of rules for the protection of personal health information in both the public and private setting. It supports transparency and accountability practices and attempts to balance an individual's right to have their personal health information protected within the custody of a custodian against the ability and rights of a custodian to use personal health information for legitimate health-related purposes. For example, the delivery of primary health care, planning and monitoring of the healthcare system, public health and safety, and health research. FIA has a limited application. FIA is applicable only to custodians. Custodian is a defined term within. A custodian is a person who has custody or control of personal health information as the result of providing healthcare services. Touch on healthcare services, as it is also a defined term within, as is personal health information. The rules of FIA apply to custodians, but all employees of custodians must be aware of their responsibilities as they are agents of the custodian. The custodian will be held accountable for the actions of their. This is interesting because I know that a number of attendees today are custodians themselves and or are employees of custodians. So where an individual is a custodian themselves, they have the obligations, responsibilities set out under FIA. Where a social worker is an employee of a custodian, they are still responsible to carry out the obligations and responsibilities as they are imposed on the custodian themselves, whether it be the Department of CSSD or Healthcare Authority. Some examples of custodians under FIA are the regional health authorities, the Department of Health and Community Service, a healthcare professional, and a healthcare provider. A healthcare professional is an individual who provides healthcare to an individual or performs a function necessarily related to the provision of healthcare to an individual. This is where a social worker is captured by FIA. A healthcare provider is a different entity altogether. It's a person other than a healthcare professional who is paid by MCP, another insurer or person, whether directly or indirectly, or in whole or in part, to provide healthcare services to the individual. So social workers are captured by virtue of the Social Worker Association Act under the definition of healthcare professional. When we talk about the provision of healthcare, healthcare means an observation, examination, assessment, care, service, or procedure provided in relation to an individual that is carried out, provided, or undertaken for one of the following healthcare-related purposes: the diagnosis, treatment, or maintenance of an individual's physical or mental condition, the prevention of a disease or injury, the promotion of health, the taking of a donation of blood products, bodily parts, or other bodily substances from the compounding, dispensing, or selling of a drug, healthcare aid, device, product, equipment, or other item to an individual or for the use of the individual, or a program or service designated as a service in the regulations. When we talk about personal health information as opposed to personal information, what are we talking about? Personal health information is identifying information in oral or recorded form about an individual. So that's interesting. When we think about personal information or personal health information, we also often think about the hard copies or the electronic copies of records that we have health information relating to. However, personal health information also encompasses oral information that may be exchanged over the phone or in discussions with a colleague or another social worker or another healthcare provider in the province. This becomes particularly important when we discuss disclosures of personal health information. And verbal disclosure, done appropriately and in accordance with the Act, is a disclosure of personal health information. A disclosure of personal health information to an unauthorized recipient, even if it's verbal, is an unauthorized disclosure under FIA and may result in a privacy breach complaint. So personal health information includes physical and mental health, including status, history, and family history, the identity of a healthcare provider, whether an individual is a blood or organ donor or has made previous blood or organ donations, registration information, including MCP or other identifiers, payments or eligibility for insurance coverage, information collected incidental to healthcare or payments, prescriptions, a healthcare aid, device, product, equipment, or other item provided to the individual, a prescription or other authorization issued by a health professional, and the identity of a representative authorized to act on someone's behalf. So FIA sets out the obligations and responsibilities of custodians in relation to the collection, use, and disclosure, sharing of personal health information. FIA's starting point is that custodians are not permitted to collect, use, or disclose personal health information unless one of two circumstances exist. The first is where the custodian has the individual's consent to collect, use, or disclose the personal information. The second circumstance is where the collection, use, or disclosure is permitted specifically by the FIA without consent. Custodians are not permitted to collect, use, or disclose personal health information if other information will serve the purpose. For example, if you simply need to know an individual's age, you should not collect their date of birth. Similarly, we have a general limiting principle in FIA where custodians are not permitted to collect, use, or disclose more personal health information than is reasonably necessary to achieve their desired purpose. So if there's no need, if you don't need to collect whether an individual is an organ donor in order to provide the services that you're providing, then there's no need to have that information on the collection form. So the starting position, before we get into incidences where collection, use, or disclosure can occur without consent, the starting position within FIA is consent. Consent is required whenever a custodian wishes to collect, use, or disclose personal health information. When we speak of consent, we are talking of informed consent, which has three criteria. In order to be informed consent must be the consent of the individual the is about. The only caveat that I would add there is if the individual is a minor or incapable. Second, the consent must be knowledgeable. This means that the individual must know the purpose for which the collection of personal information is being done for, the use to which the information will be put, and the possible disclosure of personal health information. They must also know that they have the ability to say, and that where a custodian collects, uses, or discloses personal health information, those actions will be governed by FIA. The third requirement for informed consent is that the consent cannot be obtained through deception or coercion. When these three categories have been met, informed consent has been obtained. FIA allows for implied consent within the circle of care. This means that within the circle of care, a custodian is entitled to assume that they have an individual's continuing implied consent as long as they are providing health care to that individual until or unless the consent is withdrawn. When I speak of the circle of care, what do I mean? The circle of care is those individuals, custodians or their employees, who are participating in the provision of health care to an individual, and those persons who are participating in activities which are related to or necessarily incidental to the provision of health care to the relevant individual. So as a social worker, you likely would meet all three of those categories at any point. You may possibly be providing health care, you may be participating in activities related to health care, or you may be participating in activities that are necessarily incidental. While you are actively participating within that circle, you are entitled to rely on the individual's implied consent to collect, use, and disclose their personal health information. Implied consent continues within the circle of care until it's expressly withdrawn or until you are no longer actively participating within the circle of care. So when a patient leaves your care and you don't see them for a period of time, you are not providing healthcare services or necessarily incidental services to them, you can no longer rely on the implied consent of them. Where implied consent is not a factor, we will look for express consent. This means obtaining consent as a result of an individual positively indicating, verbally or in writing, that they agree to a stated purpose. There are certain circumstances where consent must be expressed and cannot be implied under the FIA. Those circumstances are where a custodian discloses to another custodian for purposes other than providing health care. So that could be for quality assurance, auditing, other instances. Or a custodian discloses to a non-custodian for a purpose other than providing health care. The easiest example of that is a custodian providing information to a lawyer or other legal professional. Where either of those circumstances exist, a custodian cannot collect, use, or disclose personal information until it has obtained the individual patient's express consent. There are also instances expressly set out within the legislation where no consent is required. The circumstances differ depending on whether you are going to be collecting, using, or disclosing the personal information. I'll get into the various circumstances in just 1 minute. As we talked about earlier, implied consent continues within the circle of care. Implied consent is consent that can be reasonably inferred from signs, actions, facts, or by inactions or silence. As with express consent, implied consent requires that the individuals be notified at the point of collection of the intended uses and disclosures of their personal health information. You can do this through verbal notification and discussion with the patient. You may also do it by simply posting notifications, distributing pamphlets, or putting posters on your wall advising of the rationale and authority for the collection, use, and disclosure of the personal health information. You must also state the purpose for which the personal information must be used or disclosed. As mentioned earlier, implied consent will end where an individual expressly withdraws their consent. So the circumstances in which a custodian may use personal health information without include where the use is consistent with the purpose for which the information was collected or reasonably necessary for that purpose. Where an act other than the FIA requires or permits the disclosure for that purpose, information may be used without consent to plan, deliver, evaluate, or monitor health services or to prevent fraud, for risk management or quality of care, in a proceeding or contemplated proceeding, those are legal proceedings or quasi-judicial proceedings, for cost recovery or to obtain payment, and to prevent or reduce the serious risk of harm. When any of these circumstances arise, a custodian is entitled to use the personal information which it has collected without the consent of the individual. The Act also outlines disclosures that may occur without consent of the individual patient. Disclosures can occur without consent when it is necessary to provide health care and it is not possible to obtain consent, or if the individual is an involuntary patient. So if the individual does not have the capacity to provide their consent for the disclosure of their personal health information, you may disclose the information without consent. For the purposes of contacting a relative or friend when the patient or individual is injured, incapacitated, ill, or unable to consent. Custodians may also disclose personal health information without consent where they have a reasonable belief that is necessary to prevent or reduce risk of serious harm. If an individual raises questions when a disclosure is being carried out, custodian will be required to provide evidence of their reasonable belief that the disclosure was necessary. So if you're going to be relying on that provision, be certain to document why you believe that it was necessary to disclose the information and to whom, and the serious risk of harm that you felt was present. You may also disclose without consent when it's required under an act to determine or verify entitlement to services or to determine or provide payment. You can also disclose without consent to deliver, evaluate, or monitor a program of a custodian. That's either yourself as the custodian or your employer as the custodian. To an information manager, but only with an agreement. An information manager is a data service provider, an internet service provider, someone else who's going to be managing the technological services related to your personal health information. An auditor, a statistical agency, or an approved researcher. And that, when I refer to an approved researcher, I mean a researcher who's been approved by the Health Research Ethics Authority. You can also disclose to a successor custodian so long as you have a confidentiality agreement in place prior to the disclosure. So once a custodian has collected personal health information, what steps must they take to ensure that that information is properly protected? Custodians are obligated to take steps that are reasonable in the circumstances to ensure that personal health information they have collected is protected against theft, loss, and unauthorized access, use, or disclosure. They must also take steps to ensure that the records are protected against unauthorized copying or modification. And they must take steps to make sure that the records are retained, transferred, and disposed of in a secure manner. I always like to bring up this example when I get to this slide just because it's interesting. This has to be reasonable. When I talk about reasonable steps, I'm talking about reasonable in the eyes of a reasonable individual. We've seen cases across the country and across the world where a custodian has felt themselves subjectively that their methods of disposal were reasonable, and it's come to light that they haven't been. In New Zealand, In New Zealand, a physician was leaving practice, was not going to be passing his practice on to a professional, and decided that the best method to dispose of his healthcare records was to bury them on a beach. So he buried them on a beach late one evening, and the following evening, IPC, Privacy Commissioner, had all washed ashore. The information of a number of individuals had all washed ashore. So not a reasonable disposal of personal health. Another quick little story. In Toronto, a film company was shooting a documentary about 9/11, downtown Toronto as the backdrop to portray New York City. They wanted to recreate the scene as realistically as possible. So they had debris and dirt and a number of extras and actors on the set. And they were fortunate enough to have been provided with boxes of pages that they could have blowing around in the wind. And those boxes of documents, patient information that had come from a prior doctor who had thought that was an appropriate way to dispose of them. So the commissioner in Ontario then had to roam the streets of Toronto to try to contain the breach and collect back all the documents. So, reasonable in the mind of a reasonable individual, objectively speaking. Custodians must notify individuals if the individual's personal health information is lost, stolen, disposed of, or disclosed in an unauthorized manner, unless the custodian is of the opinion that there will be no adverse impact on the individual patient's healthcare or well-being. If an individual is made aware without being notified by a custodian, but is in some other method notified or made aware that their personal health information has been lost, stolen, disposed of, or disclosed in an unauthorized manner, and no notification was sent out by the custodian will be asked to provide their rationale for believing that there was no adverse impact on the individual. There is a mandatory disclosure of privacy breaches to our office, to the OIPC Newfoundland, in the event of a material breach. So that doesn't mean that all privacy breaches must be reported. Only those which fall within the definition of material breach, which is defined in the Act, must be reported to our office. Generally, when we receive these privacy breach notifications, we don't do anything with them. We use them simply for statistical purposes. We only take further action on them when we receive privacy breach notification that's indicative of a systemic issue, if it's indicative of a trend, or if it's reporting an egregious breach. So if we notice a systemic issue or a trend, we use the privacy breach notifications to help develop our guidance and tools and resources that we push out to custodians. If it's indicative of an egregious breach, then the commissioner themselves may initiate a privacy breach complaint, investigation, and or an offense proceeding. So the Act doesn't actually set out what particular safeguards, doesn't prescribe the particular safeguards that custodians must have in place to protect personal health information. However, it does give us some idea what those safeguards should look like. Physical safeguards should include securing the premises appropriately and retaining records of personal health information in a secure area. That could be a locked drawer, it could be a locked filing cabinet, or if none of those are available, a locked office. So you can only achieve the level of security with the resources that are available to you. So if you don't have a locked filing cabinet, then a locked drawer. If you don't have the ability to lock in a drawer, then a locked office. Administrative safeguards would include signed oaths or affirmations of confidentiality, mandatory privacy and security training, monitoring, enforcing, and ensuring awareness of privacy and security policies. It would also include conducting privacy impact assessments on information systems, technologies, or programs that involve personal health information. Our website has a great deal of information. If you're curious as to what your privacy impact assessment should look like and when you should carry one out, our website has a great number of tools on there, frameworks for when privacy impact assessments should be carried out and what they should look like. Technological safeguards should include instituting strong authentication measures, so strong passwords and the requirement to change your passwords on a regular basis. The implementation of encryption where appropriate, so if you're going to be sending personal health information via email or some other electronic transfer, to ensure that you have the ability to encrypt that information in transmission. Implementing detailed audit monitoring systems. So what that means is having the ability to track who accesses the personal information that has been collected to ensure that the accesses that are carried out are in accordance with the Act by authorized individuals. The Act also, for those of you who are custodians yourself, you will have to carry out and respond to access and correction requests if and when received by an individual. For those of you who are employed by a custodian, each custodian has a privacy manager in place that will handle access and correction requests from public. If you are employed by a custodian and you receive one of these requests, you should direct it to your appropriate privacy manager for your custodian. So individuals have the right to access their personal health information with limited exceptions, including where there would be harm to the individual or another person if the information was provided, where there's a legal investigation underway, or where the custodian believes that the request is frivolous or vexatious. So if you believe that the individual may self-harm or harm another individual with the information that they receive as a result of an access request, you have the ability to withhold the information from them. Similarly, if you believe that an individual is making a request to be a hindrance to your organization or to you as a custodian, you may deny their access request as being frivolous or vexatious. I would caution you that where an access request is denied or where an individual does not get the information they are seeking, they have the ability to file a complaint with our office, with the Office of the Information and Privacy Commission. And we would then review that complaint to determine if the denial of access was done in accordance with the legislation. We don't normally, on a regular basis, accept frivolous or vexatious as a reason to deny access to a person's medical information. Be cautious when you are thinking about claiming that as a reason to deny access. If you are thinking about going down that route, I would highly suggest that you contact our office and talk it through with us first. FIA also identifies the process and timelines for responding to access to information requests and correction requests. So under the Act, the individual also has a right to request correction of their personal health information. There is the ability within the Act for a custodian to deny a correction request, but there are certain steps that have to be taken, that have to be followed, if a correction request is denied. If I touch in one of these upcoming slides, so I'll touch on them now, just loosely. If you're going to deny an individual the right to have their personal information corrected, you must note on the document that the information was requested to be corrected, when it was requested, and the reason for the denial. If the document or if the personal health information is captured in such a way that a notation is not possible, then further steps must be taken so that any individual who accesses that information knows that a request for correction was made and denied and the basis on which that occurred. A request to access a person's own personal health information or to have a correction made to their personal health information does not have to be formal. An individual could request it verbally in an encounter with you. They could request it via email. They don't have to use a formal form to request a correction or access to their personal health information. There's nothing in the FIA that prevents a custodian from giving an individual access to their personal health information or discussing that information with them without a formal request, so long as access is authorized under FIA. I mentioned a little on the previous slide that there are timelines that need to be abided by. If you receive an access request as a custodian, you must respond within 60 days. You have the ability to extend that period by 30 days in limited circumstances, but you must provide notice to the affected individual. This is why these timelines are why it's of the utmost importance. If you are an employee of a custodian, that you transfer any requests that you receive to your privacy manager ASAP so that they have the full time period or as close to the full time period as possible to respond. Correction requests must be responded to within 30 days, and again, that period can be extended in limited circumstances with notice to the affected individual. Sometimes I wonder why I put this slide this far back in the deck. Probably should be up front so that you know what role our office plays, but nonetheless, here it is. So oversight by the Privacy Commission, the OIPC. FIA identifies powers and responsibilities and accountabilities for the OIPC. We have the ability to investigate any alleged breach of the Act. We have the ability to inform the public about the Act and to make recommendations to ensure compliance. Alternatively, when an individual has an issue with an access or correction request, they do not have to approach our office. They may make an appeal directly to the Supreme Court. We normally investigate alleged breaches of the Act by virtue of complaints received from the public However, we have initiated own motion investigations where we've become aware through other channels of possible violations of the Act. FIA does set out some essentials that custodians must do or be aware of in order to be compliant with the Act. FIA requires that all custodians have a contact person designated so that if an individual or a member of the public has any questions about how they can access their personal health information, how they can correct their personal health information, or any other issues they may have with their personal health information, they have someone who's identified that they can raise those issues with. FIA also requires that custodians have confidentiality agreements in place for all employees, agents, contractors, and volunteers. Where a custodian is going to engage the services of an information manager, Section 22 of FIA requires that there be an agreement in place, and the Section 22 also outlines what those agreements, the form that those agreements should take, what should be covered. FIA requires detailed policies and privacy and security policies and procedures to be created, implemented, and distributed to employees. I would highlight there that it's not enough to have the privacy and security policies in place. You must ensure that your employees are, if you are custodian employees, that your employees are aware of and fully understand what those privacy, security policies and procedures mean, and that they have the tools to ensure that they're implemented properly. Custodians must create or avail of a privacy and security training program, so the custodian can take that responsibility on themselves, or they could bring in external agencies to provide the training, such as our office, the ATIP office, the Department of Health and Community Services, or any other entity that could provide privacy and security training. Custodians are required to have a written statement of information practices. You have to make it available to the public. So you can either put that in a pamphlet that's available on your front desk. You can post it on the wall. You can post it on your website. You can pass it out to an individual when they first avail of your services. There's no mandatory format or medium for the statement so long as it exists and the individuals who are availing of your services are aware of its existence. Custodians must, again, have a notice of purposes for which the personal health information is being collected, used, and disclosed. That can be included with the written statement outlined above or can be a separate document. You must keep records or logs of disclosures, so any instance of a disclosure of personal health information from you as a custodian or as an employee of a custodian to another individual, be it a custodian or a non-custodian, must be tracked. Whose personal health information it was, what was transferred, and the date of the transfer, and to whom it was transferred. It may also be wise to keep a record of the rationale for this disclosure. You must have a process for managing what we call limited consent or lockbox requests. So if an individual has allowed you access to their personal health information, but does not want you or another individual to see another piece or a certain piece of that pie, you have to have a process in place so that that information is either blocked from you or the relevant individual that's been identified. Finally, you must have a privacy breach management protocol. I have a few examples coming up at the end where I'll outline what you need to do in the event of a privacy breach. But essentially, a privacy breach management protocol, it means that you have the ability to contain a breach, to evaluate a breach, to notify the affected individuals, and to prevent a breach from happening again in the future. So here are some of the scenarios that we were talking about. If you are accessing the electronic health record of a client, but you have to leave your desk, what does FIA require you to do, and what do you need to consider? There are a number of things you should consider. Security protocols. So are you allowed to leave your desk unlocked? Is there a policy or procedure that says when you're not at your desk, you must have your desktop locked or your office locked? Second, do you have password protection on your computer? So if it does time out, which is the last element there, if it does time out, no other individual can then pop back in to access the information. And or if you have a policy which requires you to lock your computer before you walk away, will you be prompted for a password when you return? Finally, timeouts of systems. Does your system have a timeout process after a certain period of inactivity? If you feel that the personal health information that you have access to in an electronic format is particularly sensitive, I would suggest that you approach your IT team or the individual responsible to see if the timeout can be shortened when access to that information is on your computer. Scenario number 2. You have files that need to be reviewed but would like to take them home. What should you do and what do you need to consider? What you do and what you should consider will depend on whether or not you're taking home paper or electronic documents. Electronic documents can be encrypted, may be made a lot less readily accessible compared to paper documents. Prior to the implementation of FIA, we had a number of incidents where briefcases were stolen from vehicles, whether if it was a vehicle left for a brief moment in time or overnight. And once the individual who had stolen the briefcase popped open that briefcase, there was no further protection for that information. So we would more commonly recommend that if personal health information, is to be removed from premises, it be done in an electronic format where at all possible and encrypted. At least that way, if it falls into the wrong hands, there's a lot less chance of it being accessible. Where are you going to keep the records when you remove them? So think about, first off, in transportation. If you're going to be bringing them home in your vehicle, do you have to stop anywhere? If you have to stop anywhere, is it going to be for a period of time? Can you take the bag or laptop or whatever it may be with you? And then where will you be keeping them when you get it home, and who will it be accessible to? Are you going to be using it in an office space where the entire family can access it? Are you going to be using it in an office space in a condominium building where any other condominium owner may walk in and see it? Are you going to be leaving it in a space or using it in a space where you may be required to walk away from it? You also need to consider network accessibility. So if you're going to be using it on your home Wi-Fi system, accessing information on a laptop that you're bringing home, who else has access to that Wi-Fi or network? So who else could possibly have access to network or Wi-Fi? And also, what does your employer or what do you as a custodian, what do your policies say? Are you permitted to remove personal health information? And what format should it be removed in? How long can it be removed for? When must it be returned? What's the rationale for removing personal health information? Scenario number 3, if you receive a referral from another custodian, what can you access both pre- and post-client acceptance? What do you need to consider? Only the minimum amount of information necessary to achieve your purpose can be transferred to you pre- and post-client acceptance. So if you don't need a client file in order to determine if you need that you're going to be accepting a client, then it shouldn't be provided to you and you shouldn't be seeking it. If you don't need an entire file to provide your services to the individual, then you shouldn't be requesting it, nor should it be provided to you. If you're within the circle of care, both you and the providing custodian, then you can rely on implied consent to carry out that disclosure. If you're not within the circle of care, you may need to consider whether express consent is required. Scenario number 4, you're leaving practice and transferring your files to another custodian. What should you do and what do you need to consider? Well, first off, don't leave them in a dumpster and don't bury them on a beach. Second thing is, do you have consent? Do you have the consent of the individual to pass along their file to another custodian? You should be seeking the consent of the patient before providing their file to another custodian, and that individual should be given the ability to remove their file and take it to it. These are permitted disclosures under the Act, but you should have a confidentiality agreement in place with your successor custodian prior to carrying out the full disclosure. Scenario 5, the always popular privacy breach. You've faxed someone's medical information to the wrong fax number. What should you do and what do you need to consider? This is what I was talking about a few slides back. 4-step privacy breach management protocol. So before I get into the privacy breach management program, I want to lead with this caution. Faxing someone's medical information to the wrong fax number is human error. If it's reported to our office as a material breach, we're not coming after anyone for liability purposes. Like I said, we normally use breach notifications simply to identify trends, and I can tell you this. Misdirected faxes and emails are the number 1 and 2, alternatively back and forth, causes of privacy breaches. They're human error, and we're only going to take steps to ensure that the custodian prevents it from happening in the future, and we provide the tools and resources that they need to make sure that that happens. So the 4 steps of the privacy breach notification protocol are: step 1, contain the breach. So that means ensuring that the breach cannot spread any further, whether that is going to the location and collecting the information back, ensuring that the recipient has destroyed the information, or having the individual provide you back a copy with some sort of documentation ensuring that they haven't retained any copies themselves. Step 2 is to evaluate the risk. So is there a risk of significant harm? Is there, or is this a situation where you do not believe there will be harm by virtue of the privacy breach? So losing an unencrypted flash drive that contains a patient's or a number of patients' HIV status versus losing an encrypted flash drive with that same information on it. So you need to evaluate the risks contextually presented by the breach. Once you've evaluated the risks, you need to determine whether notification is necessary, both to our office and to the affected individual or individuals. And then you need to take whatever steps are necessary to prevent it from happening again in the future, whether it's ensuring that all the pre-programmed fax numbers are accurate, implementing a policy which requires fax numbers to be entered on every occasion and double-checked, or followed up with by a phone call, whatever it takes to reasonably prevent the incidents from happening again in the future. So I touched loosely earlier about, in the previous slide, about the lack of desire of our office to go after anyone for personal liability for human errors. There is the ability for our office to initiate an offense investigation. It's not a path that we go down lightly. We only use offense investigations and proceedings where there's an indication of a particularly serious or egregious breach with some malintent. We have done this three times under FIA since its implementation, and FIA has been around since 2011. So I'll tell you how seriously we take these investigations and how infrequently we go down this path and the nature of the breach that must occur before we go down that route. But we're an individual breaches the act willfully with intent, and we have instituted what we call, like I say, privacy breach offense investigation and proceeding. So what we are essentially doing is laying a charge against the individual for a breach of the act. More often than not, these offenses arise from snooping incidents. So an individual who accesses personal health information, either information that they have valid access to in a larger database, but the information themselves is not related to their specific case file, or they have somehow come into the ability to access information that they're not supposed to have access to. These can go one step further if the individual then takes that information and discloses it to another individual who's not authorized to have information. So the next few slides are possibly fact, possibly fiction, used to drive home the point that unless you have a legitimate work purpose to access personal health information, you shouldn't be accessing that information. So that's even if you have access to a larger database. Sometimes I appreciate that there's no real ability to lock down access. You never know who your patient may be at any given time. So you need to have larger access for those purposes. However, where those sorts of large overarching access is granted, the understanding is that you will only access the information that you need to work. You're not going to go snooping or looking out of curiosity or any other untoward reason. So you're driving. Some of these are in relation to personal health information. Some of these situations are personal health information. Some of them are in relation to personal information, but the theme is the same. So you're driving to work when you experience an incident with another driver. When you arrive at work, you access a database that you have legitimate access to that links plate numbers to driver names. And you use that information to call the other driver to discuss the incident. So this is actually a fact. This is a case that happened nationally. I suspect that the one that was reported on is not a sole incident, but it was reported on nationally. And it just highlights that individual had the right to access the database, but they were accessing it without a legitimate work purpose. So we did consider it a privacy breach. It will be considered a privacy breach. You are a pharmacist who has developed friendships with several women through your church. When tensions arise, you use your access to the provincial pharmacy network to look up the other women and post the information to Facebook. This is, again, someone who has legitimate access, larger access, to a large database, but did not need to access this particular information. Again, this is a fact. It happened in Nova Scotia, I believe. And the individual went one step further. They also, beyond carrying out an inappropriate access, they used that access to then change the names of the affected individual. They changed the first and last name of affected individuals to sexually transmitted. So fortunately, that's how they were caught. So once those files were accessed, they could access changes. This example is particularly relevant. You're working on your master's in social work and you're completing an educational placement with a family health team. You use the opportunity to take the opportunity to use your access to the personal health information to snoop on family, friends, local politicians, co-workers, and others. Again, another factual case happened nationally. Not the case that's being referred to here, but very recently in the news you may have seen a case from Saskatchewan where a number of physicians in Saskatchewan used their access to the equivalent of Meditech here in the province to look up the information of the Humboldt Bronco victims. They weren't going to be providing care to those individuals. They were not and would not be providing care to those individuals at any relevant point in time in a foreseeable future. The access was out of pure curiosity. So again, the Information and Privacy Commissioner Saskatchewan deemed that to be a privacy breach, accepted a privacy breach application and complaint, and there was no legitimate work purpose for those physicians or this individual in the example to be accessing that information. You work in a hospital. You work in a hospital and you have access to information about maternity patients, both personal health information and personal information, and you sell that information to a dealer that solicits clients for registered education savings. This actually happened in Ontario very recently. So a nurse on a maternity ward used her access to the database to retrieve both personal information, so the street address, recent mothers, and their children, and personal health information of those children, so their dates of birth, et cetera, and passed it on to a dealer for RESPs, who then followed up with the clients, and of course through the jigs and the rings, it came to light that the nurse had provided the information. I'm just going to back it up for 1 second. So what I'd like to highlight is in all of those examples, the individuals legitimately had access to those databases, but the actual access they carried out was not for a work purpose. So by virtue of using their access to commit an unauthorized access, and in some instances an unauthorized disclosure, they had violated the act. This highlights common misconception that people have between confidentiality and privacy. People believe that if they look at information that they're not entitled to look at, but don't tell anyone else, then they haven't breached an act. Two different steps. Accessing information that you are not permitted to have access to, whether or not you disclose it further, is a privacy breach. Disclosing it further is a secondary. It's an additional privacy breach on top of the inappropriate act. Similarly, accessing information in a database that you have legitimate access to, so we have twofold access. You have legitimate access to the database, legitimate access to the file that you're in, but disclosing it to an unauthorized recipient, so a colleague who's not providing care or won't be providing care, another individual, a member of your family, whatever the case may be, despite the fact that you had legitimate access and a legitimate reason to be in that particular file, your disclosure is unauthorized. The recipient is an unauthorized recipient, so the disclosure is also contrary to. There are a number of resources available for custodians. If you haven't done it already, there is a FIA online training program that you can avail of. It's very good. It's precise, quick, and you do a little test as you go through to make sure you're fully understanding what programs are attending. The Department of Health and Community Services also has a manual that will help you develop a privacy statement. It will help you develop your public awareness materials, so your brochures for your written notice, for your purposes statement, et cetera, et cetera. It also has frequently asked questions. It has a risk management toolkit, so that helps you to identify what risks may be present in your organization and how you can eliminate or reduce those risks. And it also has a policy development manual. So if you haven't already created your security and privacy policies and procedures, the Department of Health and Community Services manual will help you with some templates and some guidance as to what those policies should cover, the areas that should be covered, the topics that should be covered, and who they should be distributed to, and how you should educate on those. That's our contact information. I've made the offer to Annette, and I'll extend it here now. If you want to, of course, I encourage you to raise your questions now. If you're not comfortable raising your questions now, if you want to reach out to the office after the Commissioner's email address listed there, and it will be redirected to me, and we can provide any assistance. Turn it back over to Annette now.
Thank you so much, Stacey. So yes, please, we do have a fair bit of time, so keep your questions coming in. That would be fantastic. Now is a good opportunity to raise those questions. Stacey, just wondering if you could talk a little bit more about the training that's available in terms of is it modules and steps, and reasonably how long would it take someone to complete that training?
To be honest with you, Annette, it's been a while since I've done it. It's not lengthy. I think you could probably do it in the better part of an hour, maybe 90 minutes, if I recall correctly. Of course, I do believe it has the option to jump in and out. So if you want to start it and you need to walk away, I believe you have the ability to save your progress and go back in. It does break it down into different areas of the legislation. So it does have modules, I guess, loose sense, but it does go over all the essential compliance elements.
Thank you. I know you touched on some scenarios, and you mentioned that the faxes and emails are probably some of the most common issues that have come forward. Are there any other issues that have been brought up in terms of from the investigations and those kinds of things that have been happening through the office?
That's a really good question. I do the stats every quarter, so I can say definitively that misdirected faxes and emails and snail mail are definitely the top offenders. Unfortunately, I would say that snooping is still really high in privacy breaches, and in a lot of those cases, it comes down to education and awareness. Had older rules where care professionals and providers and health authorities had some ideas about what confidentiality looked like, but there was also some old school ideas in terms of what you may intend to do, what your intentions were, what you believed was a rightful access, whether it was because you were trying to help a colleague or whether it was without any malintent. So those beliefs, we're slowly eradicating them, but they still do exist. So snooping is another one. In terms of privacy breaches, I would say that those are the top three. And often with misdirected emails, it's simply a matter of the custodian was unaware or hadn't really thought of encryption. So, or they were only encrypting an attachment, but still putting personal health information in the body of the email. So they had taken some steps, but hadn't gone all the way.
Wonderful, thank you. Just a comment that came in, so thank you for the great suggestions. So forth. So look forward to hearing the presentation again. In terms of what should people be cognizant of when documenting, but also when sending emails? Is there anything in particular you can share around that?
So, of course, when you send an email containing personal information, that in itself is a sufficient record, so long as you keep, if you have proper records management, you keep that email. In other instances where you're disclosing larger hard copies, or you're disclosing on a CD or a jump drive or some other method that doesn't in and of itself create a record, you should have a central database. If you're a sole custodian, if you're by yourself, then you can have your own binder or area that you're going to keep this. But like I say, it should be fairly comprehensive, so that if there's ever a complaint about the disclosure, you're able to go back and see what disclosure you made and justify the rationale that you had for making it. You're going to want to capture who made the request, so who the intended recipient of the information, the date on which the information is going to be disclosed and was disclosed, how it's going to be disclosed. So if you disclose it on an encrypted jump drive, if it's going to be on CD, if it's going to be in paper copies, whatever it is, what's encompassed on that jump drive or CD or hard copy. So full file, or if it's assessment or whatever the case may be, a specific test, whatever it is, should be captured. And again, the rationale, so the purpose and the rationale for the disclosure. The fuller and more comprehensive you can be in your records, in your log keeping, the better you're going to be to defend if there's ever a question raised by the individual who the personal health information is about, if they have any concern with who received the information.
And just for information, we do have, for members on the line, we do have on our practice resources section on the website a guideline document around documentation and informed consent that you can use as a checklist for going through, so that lines up with FIA as well in terms of informed consent and documentation. So have a look at that if you haven't looked at that as well. Oh, and Stacey has another point.
That's actually really important. Your log should actually capture whether the disclosure had consent or not. So if there's no consent, if you're relying on implied consent, then you should make note of that. If there's an express consent, then you should actually have a reference to where that express consent is captured.
Excellent. In terms of information that might be requested, I think we all think of the clinical chart or the record. What other kinds of information can be requested? Can a request for emails that may have gone pertaining to client care, could it include jot notes and those kinds of things? Would all that fall under FIA?
Yeah, technically, I guess it could. If the emails encompass personal health information or were related to the provision of health care, they could be captured. If a jot note is in a medical file, now, of course, you need to be careful. Jot notes can be transitory. So if it's a jot note making note of the fact that you're supposed to meet with a client on April 17th, to discuss X, Y, and Z. Once you've entered that date into your calendar, you should technically dispose of the transitory record, because if that jot note, post-it note is still in your file and an access request is made for an entire file, that jot note would be captured. It can't, once that request comes in, you can't then go through and pull out what you think is transitory and delete it. Once an access request comes in, everything is frozen in time, and you have to move forward with what you have. So yeah, a jot note, an email, a transcript, any of those sorts of things that capture personal health information could potentially be the subject of an access. And I would also highlight, if your custodian is also a public body, so for those of you who are employed with Western Health or CSSD, those entities are also public bodies, so there may be information within your files that's captured under the ATIPA as well, so it could be accessible from that front.
Excellent, thank you. Just a question around the legislation. So in terms of a social worker who might be working in a nonprofit organization but still providing health-related services, would FIA cover that as well?
Yeah, so by virtue of being a healthcare professional and registered under the Social Workers Association Act, any and all social workers would be captured by FIA, no matter if they're employed by, say, a public body, if they're employed by a health authority, or if they're a sole practitioner. It doesn't really matter what umbrella they fall. Once they fall within the definition of healthcare provider, they're captured by the Act.
Okay. Please feel free to email any other questions that you have. We still have time. Someone wanted to know, where does the circle of care end in terms of people are working with large organizations, and is there a point at which people can say this is where the circle of care ends for this particular issue?
So, as I mentioned earlier, the circle of care clearly ends when you're no longer involved actively in providing healthcare services or necessarily incidental services. So the Act does not prescribe with any great precision what necessarily incidental activities are. Again, it would be an objective analysis. So some examples that we've come up with are lab work, consultations, patient visits, where you're not specifically providing at that point in time healthcare treatments, healthcare services, but you're moving healthcare for that individual along. Once you're no longer participating in any of those activities, I think that's where your interaction, that's where you become removed from the circle of care. If you ever have any questions, if you're ever in doubt as to whether you're still in the circle of care or another individual's in the circle of care, the safest and best practice is to back out and to seek consent. Because it would be better to seek that consent and have the individual, of course, they're still providing to me, or for them to have access to my information. It would be much better for the individual to assure you than to have the individual find out feel like that healthcare provider or professional or health authority isn't involved in their care anymore.
Excellent. Thank you so much. So social workers who are in private practice are considered custodians underneath FIA. So are there resources, I think you might have touched on it earlier, that social workers can use when they're developing their policies, when they're developing their forms for informed consent and so forth?
So the Department of Health and Community Services has a great manual. It's available online, and it has a lot of templates and guidance. For those topics that it doesn't actually have a template for, it goes through issues and matters that should be covered and areas that you should delve into and ensure that you as a custodian are aware of. While we can't approve or put like a rubber stamp on anything, you can certainly reach out to our office for guidance. Definitely reviewed policies, not manuals per se, but we've reviewed policies, we reviewed procedures that certain custodians have put in place, just say whether or not we felt or not. I don't want an onslaught of everybody's policies, but we're for approval purposes. But we certainly have looked at them in the past where there's been some questions about whether everything has been covered or if there's a policy in place and the custodian feels that it may no longer be applicable.
Thank you. Have you come across anything with regards to the use of social media, and for example, Facebook or any of those social media platforms?
We've been fortunate enough here, to the best of my knowledge, that we haven't had any instances involving personal health information and social media. That said, there was the case that I used earlier with the Facebook friends and the dissemination of information from the pharmacy network in other jurisdictions. So it's not outside the realm of possibility. We have discussed the use of social media in relation to ATIPA. The best practices would be the same. If you're going to be maintaining a social media account, which Consider whether or not it's necessary, what purpose is it going to achieve. Certain that you're not posting any personal health information to that social. We have tips, best practices for the use of social media on our website. Definitely visit that, www.oipc, and get.
Excellent. Okay, not seeing any other questions come in, so I'm sure you covered all the information. But if people do have questions, or if there's information that you'd like any follow-up on, please do so. So I just want to reiterate as well all of the practice resources that NLASW has developed that's on the website. So I mentioned at the beginning our standards of practice, so look at those. We have the resources around the documentation and informed consent, and also a guideline document for social workers in private practice in terms of standards around how long you maintain records and even when you're retiring from a practice and those kinds of things. So check out those resources as well. But I do want to thank Stacey for this wonderful presentation and for sharing your knowledge, experience, and expertise with us today. You certainly provide an important overview of the Personal Health Information Act around its purpose, application, who's a custodian, all very important information that we as social workers need to have. And so while Stacey did provide a lot of information, we hope this sparked your interest in learning more about the Act and how it might apply specifically to your practice. In addition to being familiar with legislation impacting on one's practice, we also seek employer guidance and legal consultation when necessary to understand and interpret relevant laws to our practice. So I'm sure there's going to be lots of discussion happening after the webinar today. I also encourage everyone to complete the evaluation that's going to appear on your screen and let us know if there are other aspects related to the Personal Health Information Act that you would like more information or training on. Today was considered a primer on the Personal Health Information Act, so please let us know if there's anything else you want, and you can certainly provide that in the evaluation form. So the recording of the presentation, the slides and references are available, will be available on the NLASW website in the coming weeks. And we hope that you're able to pass on that information to any of your colleagues who might not have been able to attend today. And on that note, we'll sign off for today and thank everyone for their participation. We had a great number who were registered for today, and we thank you for attending, and enjoy the rest of your day. Thanks.